everybody. My name is Val Chudzinski. I'm a clinical nutrition manager with Northwestern Medicine, McHenry, Huntley, and Woodstock Hospital. And today I'm going to share with you some work that we did on improving our nutrition productivity by optimizing our Nutrition Navigator and Nutrition Note in Epic. This was on the inpatient side. So just a little background for you. You know, as inpatient dietitians, we're consistently being asked to optimize patient care, making sure that we're seeing as many patients as possible while providing excellent quality patient care. And just to look back historically, clinical dietitians historically have always identified if a patient was meeting nutrition needs and provided diet education. In the last 10 years, the clinical dietitian has really improved their skill sets to make sure they're operating at the top of their scope of practice and have added nutrition-focused physical assessments to their repertoire when completing their comprehensive assessment with patients to make sure that we're identifying malnutrition when present as well. So we know the purpose of the nutrition-focused physical assessment is to identify malnutrition, as well as we're also looking for any nutrient deficiencies or toxicity signs and symptoms when present. And we know that as clinical and registered dietitians, we are the experts and the ideal clinician to perform this task. So with adding this to our task, we definitely have seen an increase in time that it takes to do that face-to-face assessment with NFPE, and time needed to document is often listed as an employee registered dietitian's dissatisfier, and top reason listed for the reason that people are not able to assess more patients, as well as being able to participate in those key interdisciplinary activities. So the scope of our project was to analyze the current inpatient charting process, to identify if there was any areas of opportunities, and to allow more face-to-face patient encounter time, as well as to improve our overall dietitian job satisfaction. So you can see on the left over here, oops, here we go. We analyze our current practice prior to our implementation, the time that it took us to do initial comprehensive assessments as well as our follow-up assessments. The initial assessments were taking about 60 minutes, with about 30 minutes to look up data, 15 minutes to round with the patient, and 15 minutes to finalize the charting plan. And our follow-up assessments were taking about 45 minutes and about 15 minutes each for the data collection, rounding, and finalizing the charting plan with the patient. So we did utilize a process map, the 5 whys analysis, and a benefits effect matrix to identify our biggest areas of opportunity and plan as a team for the most impactful interventions. And just to share with you guys, so you can see this very closely, we identified that our key problems was that we did not have a standard workflow when looking up information and gathering information that we were going to use to round on our patients. We were doing duplicate charting, and we had some old processes of excessive paper with duplicate charting as well. So to share below, we implemented 3 different interventions. We took a hard look at our Nutrition Navigator on the left-hand side over here, and we were able to remove 14 flow sheet rows from the Navigator documentation. We removed the date and time of the assessment due to that date and time could be pulled from the charting that was completed, the encounter reason, the percent of meals documented, as this was documented by the nurse, and we could pull this in a smart phrase. Diet and oral nutrition supplement order was a smart phrase. We did not think that we need to document the estimated carbohydrate intake on every patient. And then the enteral and parenteral access, enteral and parenteral RN documentation, edema documentation, skin breakdown, GI documentation, and speech swallow eval, and food insecurity documentation. This was all documented by our other clinicians. And we were pulling it into our Navigator. So we decided that we were going to stop documenting on that, and we were going to pull in smart phrases into our actual note to prevent any kind of duplicate documentation. And we were really going to, anything that was within normal limits, we were going to remove from our process of documentation. So that removed 14 flow sheet rows. And then next, our topic was we really looked at our RD note. So the note process in Epic allows smart phrases. For those of you that do not use Epic, just to explain, and you can pull in information from other clinicians' notes. So we took a hard look at this and we pulled in any documentation from other dietitians, nurses, speech therapists, respiratory therapy, into our note, and then that eliminated us from needing to double document, as well as it it gave us a more consistent process of how we were reviewing the information. And it changed our workflow process by allowing us to analyze the individual plan by scrolling up through our note and documenting in our summary, versus pulling from different activities for information. Definitely increased or decreased the amount of time that it took us to complete this step. Then we also looked at the smart phrase optimization, and we pulled together a nutrition navigator smart phrase that prompted us with all of the key information that we needed to complete our nutrition navigator. And then we also looked at a key smart phrase for nutrition rounding. So historically, this data was handwritten on a cheat sheet before we went and rounded with our patients that had assessments due for the day. And this smart phrase pulled a easy one-page document that we were able to copy and print out, which worked really nice. So these two smart phrases, to clarify, do not get saved into the actual EMR. It's used as a documentation helper to speed up your workflow. So that worked really well for us. And you can see on to the right over here, this improved our time significantly. So it improved our initial assessment from 60 minutes to 45 minutes, and it improved our follow-up time from 45 minutes to 30 minutes to complete, which gave us more face-to-face time with the patient. It allowed an increased number of patients to be seen. We did put some key documentation for malnutrition identification in our review, which helped increase our identification of malnutrition because it pulled all the key factors together for easy summary and identification. My team reported improved job satisfaction, and it gave them a little bit of time to work in areas of interest for quality improvement. So our control measure is our goal is 100% of daily assessments to be at least 9 to 10 patients. And our threshold for action is if we have 2 consecutive months below the 95th percentile. So our conclusions for this project was that eliminating documentation of information that is already in the EMR, reduces time for the RD and reduces charting errors from transcription errors. Building smart phrases that pull key non-RD clinical information prevents the need to hunt for that information in different areas of the EMR and creates a standard workflow of the process for the workflow. Building smart phrases for key workflows that RDs were previously writing down. This creates a consistent process for rounding and eliminates time spent looking up and writing information. And for clinical nutrition managers, just making sure that you're creating productivity reports and eliminating the need for your team to manually gather their productivity. This saves a significant amount of time as well, excuse me. So this is my project, our project in a nutshell. If you have any questions, we would be happy to connect. Thank you and have a great day. Bye-bye.